Thanks again. We're going to go ahead and move on to acute ischemic stroke, something which is near and dear to me. I've spent most of my research career in endovascular therapies. A conflict which I have is that I was on the data safety monitoring board for one of the recent trials we'll talk about, and I was compensated by the sponsor of that, Stryker Neurovascular, for the time involved in that. Acute ischemic stroke is now a less disabling condition in the United States than it had been years ago, in part because of prevention. But still, it's the fifth leading cause of death worldwide, and in some countries it's number one. So in China, for example, hypertension-associated intracerebral hemorrhage is one of the most common causes of death. Very preventable disease, but also now with very good evidence is a very treatable disease. And we're first going to talk about we're going to talk about TIA, basically, and how you manage that, followed by somebody who's having a stroke, and talk about both tissue plasminogen activator, and new with ENLS version 3, we'll talk a lot about endovascular stroke, because many of those trials just concluded in between version 2 and version 3. So at the end of this, you're recognizing the signs and symptoms of acute stroke is key as a learning objective, how to work with pre-hospital services to deal with the management of them, and then understanding how brain imaging is helpful in acute stroke, and we'll talk about the objectives of acute ischemic stroke in a moment. So the clinical diagnosis of stroke is redundant. Stroke is a clinical diagnosis. You don't need an imaging study to tell you that someone's having a stroke. You say they're having a stroke if they have the typical sudden onset of a focal neurologic deficit that you can explain by a vascular cause. So if it fits a particular pattern of a large vessel inside the brain, like the middle cerebral artery, you would say it's probably a middle cerebral artery stroke. It's typically sudden onset maximum at the beginning. You cannot tell, however, whether or not the person's bleeding into their brain or whether they're having an ischemic stroke on clinical grounds alone. Although hemorrhagic strokes tend to evolve over time, so they're not maximum at onset, the two really cannot be distinguished side by side well enough for you to give tissue plasminogen activator to a patient without a scan. So the role of imaging really is to tell you the difference between those two. In the pre-hospital evaluation, before you get to imaging, though, we like our paramedics, our pre-hospital providers, to get some history and physical on the patient. That's part of their usual workflow. But a key aspect of that is the time of last known well, and that's key for the tissue clock of whether a person can receive these types of therapies, along with their some measure of blood glucose, because that can be a stroke mimic. Some paramedics draw labs on the way, and those are handed off when they get to the hospital. Sometimes in the emergency department, those labs are drawn. But we're also asking now, and has been a fairly large standard, to have the paramedics call ahead to the receiving hospital so you know someone's coming. In the hospital, many stroke centers have hospital activation systems that are activated once a patient's in their midst to go and evaluate them in the ED. And in the first hour, we want to have that system activated, certainly get their vital signs, keeping their SATs at group 94 with supplementary oxygen as needed. Again, nail down the last known well time. NIH stroke scale score is important because it helps us stratify treatment decisions, and it also gives you an idea of stroke severity. If you're not trained in NIH stroke scale score, there likely is somebody in your institution who is. It's free to do. It's through the American Heart Association. Some nurses use this now for handing off patients from shift to shift, like they've done with Glasgow Coma Scale. That's not what it was originally intended for, but it's certainly a good way to get a lot of practice in doing it. But it is standard of care now to determine the NIH stroke scale before early in the treatment process. They get some form of brain imaging in the first hour. Their medication list is key to know about, but mostly focusing on the presence of anticoagulant medications because those can contraindicate TPA. They get IV access with 118 gauge, if not 2, and certain labs drawn and an EKG be done. Those are the things that we'd like to do in that emergency setting. All of those can be done in parallel. We do not typically use any of the results of laboratory studies to preclude administering TPA if your history tells you otherwise, which we'll get to. So once you're in the hospital, you've had an imaging study done, so you know it's not a hemorrhage. If it was a hemorrhage, it would go down the ENLS ICH route. But in this case, I'm going to assume that that head CT was either normal or it shows something but doesn't show any blood. And in transient ischemic attack patients who have a focal onset neurologic deficit that can be explained by vascular cause, but doesn't last any longer than 24 hours, has a TIA. And TIAs typically last 10 to 20 minutes. A hemiparesis or speech dysfunction or visual field problem that comes and goes, almost always it's painless and it clears by definition completely. If that person gets a brain scan later, like an MRI, and it finds a little area of diffusion positivity, so there was an infarct, we now call it a stroke. And so patients are admitted for stroke under the DRG of stroke. But if the person has no imaging subsequent to the CT scan and they're neurologically normal, you call it a TIA. You can help figure out how high a risk that TIA is for subsequent stroke by applying the ABCD2 scale. And this scale is, again, something to look up or look up in the app, on the app, that you get a certain number of points for certain clinical factors, like your age, your blood pressure at presentation, whether or not the clinical features of TIA allowed for speech and language disturbance or unilateral weakness. And unilateral weakness gives you more points because that's more predictive of a true TIA affecting the motor system. And then you get points for duration and whether or not you have diabetes. That's useful because patients with points of 0, 1, 2, and 3 typically have a very low risk of subsequent stroke, and many hospitals manage these as an outpatient. So the way that they're treated is that they will start them on some antithrombotic medication, aspirin, clopidogrel, Persantin plus aspirin, usually a high-dose statin, Lipitor 80 or atorvastatin 80 is commonly used. You might moderate that in elderly patients. Some form of carotid imaging is key in this very initial assessment because if you've had a TIA relative to a carotid lesion, more than 50% of your risk of subsequent strokes in the next couple days. So the old model of TIA, then do a carotid ultrasound in 2 days and then refer to vascular surgery in a week is no longer the standard. It's image them now, and we use CT angiography of head and neck in the emergency department to look at the carotid, so it's done immediately. TTE is of some value, but debatable. But more and more people are now going to 30-day ambulatory monitoring to look for intermittent atrial fibrillation if they didn't have AFib on their first EKG. And then, of course, encouraging smoking cessation. Patients who are higher risk, 4 points or higher, are often admitted, and they're watched closely for the reason that their risk of stroke is so high that they might re-stroke or re-have a neurologic presentation in the next 12 hours, and TPA can be administered to those individuals in the hospital under hourly neurochecks. That varies from institution to institution, but it's worth, if you have a TIA, calculating the ABCD2 score and knowledge of that when you're referring for follow-up. If the patient still has symptoms when you see them, it's likely going to be a stroke. And in that setting, then, want to have a fairly organized and rapid approach to this. And for those of you who are already part of primary or comprehensive stroke centers, I apologize. This is all review. For those of you who may not have had as much experience with stroke patients, this is important now because it's so protocoled, and it's protocoled because we want to treat patients very quickly. So for example, our Kaiser hospitals in California, their goal is to have a patient treated with TPA and referred for embolectomy to an institution that can do that within 30 minutes of arrival. So that includes imaging, TPA administration, figuring out the transfer and getting them into a transport vehicle in 30 minutes. That's just so different than how we used to do this. So it's evolving. So let's give a case of a patient who's 65, presents to the hospital who has right-sided face and arm weakness. They have some language difficulty. I'm not going to quiver whether it's an aphasia, but they're having trouble with producing words. It's happened 30 minutes ago, and you have a witness that said, I know it, I was with her at the time, and this is when it happened. She has hypertension and high lipids and takes simvastatin, blood pressure medications, and aspirin 81 milligrams. When she presents, her blood pressure is 160 over 90. She has an O2 sat of 98%, and airway, breathing, circulation appear to be fine. She has an NIH stroke scale of 14. 0 is normal, 42 is moribund. 14 is a high predictive value that the person has a large vessel inside the brain enclosed as opposed to a small vessel. The rest of her exam's unremarkable. She doesn't have AFib, as far as we can tell, and a finger stick for glucose is normal. She has a non-contrast head CT, and then somebody put an arrow on this. So what it shows is no hemorrhage, but the arrow is actually showing you a hyperdense vessel in the middle cerebral artery territory. That's blood clot that's actually formed and been pushed right into that vessel. This is highly specific for middle cerebral occlusion, but it's insensitive. So maybe two out of 10 patients who have a middle cerebral occlusion, well, you'll be able to see it. Most centers now couple with CT angiography, where they give additional contrast and look for the vessel being occluded, and that is rapidly becoming standard of care in nearly all stroke centers in the world. So one will know very quickly whether they have a middle cerebral occlusion, which will be relevant in a moment. So the first question is, should I treat the patient with TPA? There are a lot of changes actually in how TPA was originally label changed to be used in stroke in 1996, and those have been subsequently changed a bit. Initially, there were things like, if you'd had a stroke 3 months ago, you can't get TPA. That's no longer an exclusion. If you had a seizure at the time, that's no longer an exclusion. A lot of these were methodologic exclusions for the study so that they didn't take patients who had a perfectly normal prognosis. So if you had seizures, and these are post-ictal patients, they all get better, so the TPA wasn't going to make any difference. So the trial design excluded those patients. It doesn't mean that TPA is unsafe in seizures, nor is it unsafe in migraines. So if you're treating patients actively for stroke, somewhere about 2 out of 10, 1 out of 10 are going to be false positives who you give TPA to, and you should congratulate yourself because that means you're unlikely to miss people who are really having a stroke. So the actual exclusions are fewer. Now, there's an additional time window of 3 to 4.5 hours, which was based upon a European study that extended the time window beyond 3 to 4.5 hours. And they specifically, again, for methodologic reasons, said they didn't allow anybody under age 80 or patients who had diabetes in the trial. Most stroke centers ignore this now. So it is off-label use to administer TPA beyond 3 hours in the United States. The FDA has not approved it. It's approved in European countries as well as in Canada. In Japan, they use a lower dose, but go out to 4.5 hours. So there are variances internationally that are here. But the protocols talk about these relative exclusions beyond 3 hours. So our case is under 3 hours. Remember, it happened just 30 minutes ago. She had a significant NIH stroke scale score with normal blood sugar, and her head CT showed this hyperdense vessel sign. She had no contraindications after going through the list of these, and her blood pressure was less than 185 over 110. Why is that number important? It is felt that if you're hypertensive at the time that you give TPA, you can have a higher risk of bleeding into the brain. So if you had a blood pressure of 210, over 120, TPA may be fatal. So in those settings, we lower blood pressure a little bit of labetalol, a little bit of nicardipine, just to see if we can bring it down. And if you can't get it down to 185 over 110 or less, don't give TPA. So in her case, she came at 160 systolic, so she was below that. She is an IV TPA candidate, and she's given alteplase or single-chain TPA. So we like to have 2 peripheral IV lines in case the patient later develops some hemorrhage, like a GI hemorrhage with a TPA. You measure their actual body weight. It's required by JACO certification that it be measured. And then you mix 0.9 per kilo, maximum dose 90 milligrams. You give a bolus of 10% over the first minute, and the rest over an hour by infusion. If perchance the patient was suddenly gotten worse, then you'd be concerned about an intracerebral hemorrhage. This happens about 6% of the time. At least that's what it shows in the trials. And if that's happened, the person's bleeding into the brain, it's fatal in 50%. What you can do, and the patients are at higher risk for intracerebral hemorrhage are those who have significantly higher Knight stroke scale scores. That said, patients overall, regardless of their baseline stroke severity, do better with TPA than without getting it, but your hemorrhages are skewed in this population who are sicker. If it happens, stop the TPA, measure their vital signs Q15 minutes, which you would do anyway following TPA. You might consider empirically doing treatments like Christy talked about to lower intracranial pressure, say a dose of mannitol or all, but your quickest thing to get an answer of whether they're bleeding or not is to get a CT again. Just non-con CT is 100% sensitive for blood. Let your neurosurgeon on call know, and if you don't have one, figure out how you're going to transfer the patients. Cryoprecipitate may be helpful. It's never really been studied. It said you should give it, maybe give a unit of platelets as well if the patient had been on aspirin, but not much of this is evidence-based. And as I said, I think in the majority of cases when it happens, it's often fatal regardless of what you do. Most surgeons won't operate and do a hemicraniectomy in a patient who has TPA recently infused. So it's part of the complications of the drug. We know now that if you have a large vessel inclusion inside the brain, a carotid terminus inside, just as the carotid comes into the skull, into the subarachnoid space or the middle cerebral artery, that those patients do very well if you do an embolectomy on them, in addition to be giving TPA. So there's a whole bunch of these things. Some look like egg beaters and corkscrews and everything else, but all of these have been studied in some very important trials that have shown without dispute now 6 major prospective randomized trials have shown that opening the vessel with things on using stent retriever type devices like the one you see on the right improves neurologic outcomes significantly if done under 6 hours. The recommendations for that include if they're TPA eligible, give it, like we have in this patient. If they're not TPA eligible, this is the only thing you've got to do for them. A number of centers don't treat patients who are already quite neurologically disabled to begin with, and people have different distinctions of what that is. But a patient who is end-stage dementia, who's a member of a nursing home, may be somebody that you decide not to intervene on, while somebody who is anyone here in the room who's active and working and so forth would be eligible. That's up to your own institution. They have to have a large vessel occlusion of the internal carotid artery or the proximal middle cerebral, and then a significant enough NIH stroke scale points to qualify. The aspect score is a complicated radiologic score that I think a number of people are moving away from, but you should get catheter into groin within 6 hours. So I was talking with our chancellor about our time to groin access when patients show up, and he sort of looked at me and said, could you use a different term? You know, like when I'm talking to the public, I'm not really sure I want to tell them how fast we can get to your groin if you come to our medical center. I said, okay, I got your point. But that's one of the measurements, is to see how soon can you do this. We know that the earlier you treat, the better patients do, and I think a worldwide goal is to try to do this much, much faster than is currently the case. So in our case, she got TPA. Her CTA that was done subsequent, which I haven't shown you, showed that she had a middle cerebral artery occlusion, which we felt was going to be present because of the hyperdense vessel sign. She's taken to endovascular therapy, and there they do a catheter approach. This left image is the AP angiogram of the left middle cerebral artery, and you can see where the arrow is, the vessel's occluded. And then after a pass with the stent retriever type device, the vessel opened up. So she's had treatment, and what's remarkable about many of these patients is that they get better as soon as you're done with the case. So some patients, the classic is that they've been restrained in the right arm because in the left arm in this case, because they're moving that spontaneously, but the right arm's not restrained because it was paralyzed. Then as soon as they take all the blue towels off and everything, the patient reaches up with the right arm and extubates themselves. It's like, okay, it's not so good they self-extubated, but it's pretty cool when you see it, right? And we're seeing that now with some degree of commonality, which is wonderful. This disease with this large vessel occlusion is upwards of 50% fatal, and certainly of those who survive a tremendous amount of morbidity. And in the beginning of July of this last year, just for example, we treated 11 patients in 10 days. The first 6 walked home. So that just we never saw that before. So these treatments do work, and they need to be done quickly in an organized system. So when a patient's handed off, I think that what's critical is their age. We'll talk a little bit about pediatric cases in a moment. Are they intubated or not? When was the time of onset, their NIH stroke scale score? What was their vascular imaging that you did? Did they get TPA, and were they referred for endovascular therapy? Usually, many people are involved in the chain of survival here, and this is already known, or they're part of it. But if the intensivist who's receiving the patient afterwards hadn't been a part of it, those would be the things that he or she would want to know. Once they're admitted, you want to keep telemetry going, because atrial fibrillation is such a common cause of these large vessel strokes that if you find it, there's going to be a treatment decision to anticoagulate the person longer term, and often you just pick that up on tele. Maybe you already know that from the 12-lead EKG. You want to keep them euvolemic. You do not need tight control of blood glucose, but 140 to 160 is probably fine. We recommend you suppress fever if you can. We're not sure if that's helpful, but we recommend it. And then if TPA was given, they're not supposed to get any anticoagulation or any antiplatelet agents for 24 hours. So you have to make sure that your admit orders actually say to start that after, and usually at 24 hours we do a head CT scan to see that there's no hemorrhage. So once that's negative, then you can start the antithrombotics. And then don't put in a Foley for a bit. Urethral trauma with TPA on board is a bloody mess, as you know, and it can also clot up catheters, so it's best to not do that unless you have to. Same with nasogastric tubes. All patients who've had a stroke need swallowing assessment as well. Now, kids are different ball of wax. Most people, when have you ever seen a kid with a stroke? Well, it's actually not that uncommon. And at our institution, we have 2 pediatric stroke neurologists that have set up clinic, and it's amazing how many strokes are out there. One of the most common causes for this is sickle cell, where they develop an arteropathy due to the chronic anemia. But cardiac anomalies that lead to cardioembolism in kids is really the more prominent cause. There is a pediatric NIH stroke scale score. It's kind of hard to do language in kids who are, under 1 year of age. You say basic. But there are validated scales that help with kids. And there are lots more stroke mimics in kids. Especially a high migraine can simulate stroke quite a bit, and kids might not be the best at telling you when things began or what their symptoms were, so probably a lot more mimics that get treated. There was a trial to do TPA in kids. It just never enrolled anybody, and so the trial was canceled. Various centers, some agree to use it, some say they will never use it, and then endovascular therapy is even further from evidence basis. But in certain cases, it makes sense to treat children endovascularly.